Okay, done it. Okay, done. Done. Okay, okay.
Hi, once again. Hi, everyone. Hi, everyone. We are going to start our webinar. And here I'm going to present Mr. Judah David. He is going to be the presenter for this oxygen therapy webinar. I hope this is going to be an eye opener for one and the participants. It's a really very good, interesting topic which he is going to present. He is working as a chartered physiotherapist in NHS in UK. He has a wide knowledge in cardiopulmonary department. You can even ask your question cardiopulmonary regarding cardiopulmonary subject. And I'm straight away going to I'm going to tell him to start this webinar. Welcome, Mr. David. Thank you for accepting this webinar in a short notice, and kindly take the lead, sir. I'm going to make you a presenter. David, you can start your presentation.
Thank you. Can you all hear me now?
Of course, I can able to hear you, David.
Thank you. Thank you.
Attendees, if you have any trouble, please message me in Q&A section. The presentation is going to get started. It started. Okay. Thank you. Thank you, Mr. David. Please start your webinar.
Thank you. Good afternoon, everybody. It's a great opportunity to meet you all through this webinar. And I would like to extend my personal thanks to Franklin, a senior consultant physiotherapist, and Janet, a senior consultant occupational therapist who works in HAMSA Rehabilitation for this opportunity. Today, I am planning to talk about oxygen therapy. As it is a very commonly known treatment. We might have heard loads of times in the hospital, but still there are a lot of uncertainty, and this particular topic is not very clear among healthcare professionals. So the aim is to clear those doubts and give you a clear understanding of what is oxygen is and how it can be administered. So my aim is I would like all the audience to understand oxygen therapy principles and aim of the oxygen therapy, what is the indication, and talk about the flow and the delivery system. So that means how many liters of oxygen and how many ways we can provide this oxygen to our patients. So to achieve this, I put a couple of topics in my presentations. So these are the contents in my presentation. I don't want to go through these one by one because we will be seeing those slides next. So let's talk about a little bit of principles about oxygen therapy. The oxygen concentration in room air is 21%. My small question is, do we have a clear understanding what does this mean to us? Of course, I'm not questioning everybody. If it is not clear, this may be a good time to reflect on what does this mean to us, 21% on room air, what we are breathing. So to make it simple, to explain that very clearly in a simple form, imagine you are breathing 100 ml of air into your lungs every time you breathe. It's an example. So if you imagine you breathe 100 ml of air into your lungs, so it means in 100 ml, the 21 ml is oxygen and the rest of the air is other airs, which is nitrogen. Nitrogen is the most part of the air, which is 78%, and you got argon and you got carbon dioxide. So to make it very clear, if your tidal volume, which is like 100 ml, your oxygen concentration in that is 21 ml. So imagine if your tidal volume is 500 ml, which is a tidal volume for adults. So approximately in 500 ml, 100 ml is oxygen and 400 ml is rest of the air. That's what this oxygen concentration on room air 21 means. The other way of saying is fraction of inspired oxygen. So our fraction of inspired oxygen for a healthy adults who's breathing room air is 21%. So oxygen has a vital role in the management of hypoxemias. Hypoxia means low oxygen. And when we talk about respiratory failure, we have two types of respiratory failure. One is a type 1 respiratory failure, another one is a type 2. So in type 2, there is nothing wrong with your carbon dioxide, but your partial pressure of oxygen is low. But in type 2 respiratory failure, so you got a high carbon dioxide and low oxygen. So to make it even easily to understand, a type 1, only one problem, which is low oxygenation. A type 2, two problem, high carbon dioxide and low oxygen. Oxygen is probably the most commonly used drug in the hospital. I think we all agree that very clearly. Oxygen is a prescription drug. This is something I would like to stress on because I don't think so it's used as a prescription drug. So oxygen is a prescription drug and it should be prescribed by a prescriber who has got a clear understanding of oxygen therapy. But it is the least valued in terms of correct prescription, delivery, and risk management. So people prescribe oxygen without realizing whether it's done properly, what they're trying to achieve, and without analyzing what would be the risk to that particular patient if the oxygen is not prescribed properly. So those are the areas we're going to clear and clarify those doubts. So by giving oxygen, what are we trying to achieve? To maintain the patient oxygen saturation levels as closest to the normal value as possible, given the patient current disease state. So for example, if some adults without any respiratory problem, they haven't got any respiratory complications, they haven't got any chronic conditions, their normal saturation is 95 to 100%. But for example, if patients with the chronic obstructive pulmonary disease, if they are diagnosed with the COPD, according to BTS, the recommended saturation for chronic condition patients with the COPD is 88 to 92. So why I'm saying this, if you are treating a patient with a chronic obstructive pulmonary disease who's got a chronic respiratory conditions, and if you are trying to achieve oxygen saturation 95 to 100 for them, you're wasting your time, because you will be able to achieve those oxygen saturation by giving significant amount of oxygen. As soon as you try to stop the oxygen, their oxygen level will automatically come down because their lungs are damaged so much. The amount of oxygen saturation they may be able to achieve maybe 88 to 92. And also by giving too much oxygen to these patients, you may be putting them at a huge risk of hypercapnic respiratory failure. Basically, giving oxygen to COPD patients inappropriately can drive the CO2 to a higher level. So their carbon dioxide level will go up and they will become unconscious, and then they could go into respiratory failure and followed by respiratory arrest. So this is something very important for you guys to know: who you're treating, what is their background, what is their clinical conditions, and what is acceptable saturation level for that particular patient. So the important thing is, the only way we can find out is to clearly know about your patients. The history and the past medical history is a key factor, and social history. Sometimes patient may not be diagnosed with COPD, but they may have a significant history of smoking, maybe 20 to 30 cigarettes a day for 30 years, 40 years. There may be undiagnosed COPD. So these things you need to really consider. Right. Another important thing is, why are we giving this oxygen? The important thing is to prevent tissue hypoxia. So by giving oxygen, if people think you're treating underlying condition, which is wrong. So the aim of the oxygen is to prevent tissue hypoxia caused by this condition. For example, people may have hypoxia if they have a pneumonia. People may have hypoxia if they have a pulmonary embolism. People may have hypoxia due to heart failure. People may have hypoxia due to atelectasis, which is lung collapse. So we are not treating the underlying problem. We are correcting the symptoms caused by the underlying problem, which is hypoxia. So obviously, the fundamental problem has to be treated. For example, if patients have pneumonia, they have to be treated with antibiotic along with oxygen therapy. If people have a pulmonary embolism, which has to be dealt with anticoagulants along with the oxygen therapy. Heart failure has to be treated along with oxygen therapy. So when the oxygen therapy will work effectively when the appropriate treatment is given to the patients to treat the underlying problem. So when the pneumonia gets better, the oxygen level you're giving to the patients also can simultaneously come down. Only by giving oxygen, the fundamental problem is not going to be resolved. Okay, that's something we need. I know it's a treatment, but it is not the one which is going to cure the problem. So, what is indications for oxygen therapy? So, as I mentioned, to prevent hypoxia in the following conditions. Why we need to prevent this hypoxia? For example, if your oxygen saturation is, say, 95 to 100 is normal, due to your health condition, say you got pneumonia, severe pneumonia, your oxygen saturation is dropped to 85. So that means your oxygen saturation is not acceptable for your health condition. For your health, for your age, for your body, the acceptable saturation should be 95 to 100. But due to pneumonia, it's dropped to 85. So imagine you are saturating only 85% of oxygen throughout your body. That means your brain also will be saturated only 85%. Your kidneys also will be saturated only 85%. And all your vital organs will be saturated only 85%. In a long period of time, all these vital organs will start to fail in a duration of the time. So basically, you came in with a pneumonia and that caused severe hypoxia. If the hypoxia is not looked after properly, in a matter of hours or day, you will be ended up in having multi-organ failure because of hypoxia. That's the reason it's important to prevent hypoxemia in the following conditions. So there are some examples here: asthma, COPD, pneumonia, bronchiolitis, respiratory distress, cardiac or respiratory arrest, pulmonary embolism, shock, sepsis, heart failure, myocardial infarction, carbon monoxide poisoning, post-operative. The list can go on. These are some examples. So try to understand the fundamental idea of oxygen is to prevent hypoxemia in the following conditions so that you can prevent the tissue damage. As I mentioned, oxygen should be prescribed on the drug chart with a target oxygen saturation. So example, if you're a doctor or if you're a healthcare professional, if the patient is on oxygen therapy, it's important to check the prescription to see whether it is written how much saturation you're aiming to achieve and what amount of oxygen is allowed for the patient. So it's important, for example, if you're treating a COPD patient, it would be very clear if the doctor can write the acceptable aimed saturation is 88 and 92, in between that, and then the amount of oxygen should be given is 2 liters or 3 liters via what type of device. The prescription need to be based on the current clinical need. So what is their underlying problem? What are we trying to achieve? So for example, if patient with a pneumonia, if their saturation is say 90, and you're trying to achieve, I said 95 to 100 is normal. So no point in just trying to give, for a sake, 10 liters to achieve 100%. So they may have to say, go from 5 to 10 liters to see what oxygen saturation the patient can achieve. If the patient is achieving 98% oxygen, I'm saying an example here, just by 3 liters oxygen by a nasal cannula, then that is more than adequate. No need to give 10 liters. So that's important. And it's important to understand the clinical need of the patient and what is the patient diagnosis is. Sometimes patient oxygen saturation may need on PRN as needed. Sometimes patients are going home with LTOT. I completely understand. Some people may not be aware of this. Some people may know. There are a lot of patients with chronic conditions at home will be on oxygen cylinders or oxygen concentrator. We call them a long-term oxygen therapy, LTOT. So that again has to be written very clearly by the consultant who's discharging the patient. What is the patient acceptable saturation level? How much oxygen they should be on at home? The important thing is monitoring of this patient is essential. It's a key factor. When patient comes to accident and emergency or casualty, that's where most of the time the oxygen is started if there is a need, or maybe in the ward. So most of the time, this is determined by pulse oximetry. Pulse oximetry is a very small device. You put it on your finger, which tells what is the patient's saturation levels, because the pulse oximetry measures the oxygen flow in your finger, and then it multiplies, and then it converts into percentage. So the normal saturation is 95 to 100, and then for COPD patients, 88 to 92. Why I am saying this, if the patient is a known COPD, if they are coming to the hospital with some kind of infection, if they are already achieving 88 to 92 with their pulse oximetry, there is no need to start this patient on oxygen unless the patient is in extreme breathlessness. So sometimes, most of the time, we do that routinely. Oh, patient has come with a chest infection, let's put them on oxygen. That is not actually correct management, and that is not necessary. So that's the reason it's important to know what is their normal saturation level, what is their acceptable saturation level. For example, put it in this scenario. If somebody is coming with a chest infection and they need to be started on antibiotic, but you're looking at their saturation level, it's 96. Would you start that patient on oxygen? And because you know their saturation, what they're achieving is normal, so there is no need to start them on any additional oxygen. But if their oxygen saturation drops below acceptable level, then it will be appropriate to start them on adequate, right amount of oxygen. Then some patients can deteriorate. Then the doctors may consider to do a blood gas, which we call them arterial blood gas analysis. You can also do venous, but most of the time it is arterial blood gases. They take a blood from the artery and put it on the machine, and then the machine gives you the level of partial pressure of oxygen and carbon dioxide, and also it gives you the saturation. But most of the time, people will be started on oxygen based on their saturation level. But arterial blood gas also important, because your arterial blood gas will tell what type of respiratory failure patient is on, whether they are in type 1 respiratory failure, they are in type 2 respiratory failure. I really want you guys to focus on this particular slide, please. First, we will talk about the oxygen flow. Then we will talk about the delivery system. If you look at the flow, on your right-hand side of the slide, you got the flow meters. The flow meters are commonly used in the hospital, and majority of the flow meters throughout the worldwide has got a maximum of 15 liters capacity. So that's the reason on the left-hand side, I put it and I stopped it up to 15 liters, because that's very common flow meters used throughout the world is a 15 liters flow meter. So if your oxygen is flowing from 1 to 5 liters, we call them a low flow oxygen. If the oxygen from 6 to 10 liters, then it is a medium flow. But if it is from 11 to 15 liters, then it's a high flow oxygen. That means maximum you can give 15 liters using that particular flow meters. There are different flow meters available which can give up to 30 liters, which is not commonly used in the hospital. On a very specific area, they use those flow meters, but very common one, if you walk into any intensive care unit in India or in USA or in UK, in ICU, the flow meters you will see is up to 15 liters. Let's talk about the delivery types. There are two different types of delivery equipments you can use. One is a variable system, another one is a fixed system. First, I am going to talk about the variable system. What is variable system means? That means under these particular devices, you will be able to tell only how many liters you are giving it to the patient, but you won't be able to tell how much oxygen percentage the patient is achieving. So please try to understand this. If you're using any one of the variable delivery system devices, you will be able to tell only how much oxygen you're giving, but you can't tell how much percentage of the oxygen the patient is getting. For example, go into my next slide. So I'll go back here. A simple example I'm going to give you here. A nasal cannula. The British Thoracic Society, World Health Organization, the NICE guidelines recommend you can give up to 1 to 6 liters oxygen to a patient using nasal cannula. But if you look at the percentage of oxygen, it varies from 24% to 44%. So there is no set percentage a patient can achieve by giving oxygen via nasal cannula. For example, if I put myself on 2 liters oxygen via nasal cannula, if somebody 6 foot patient is on 2 liters nasal cannula, what we are both trying to achieve will be completely different, because the oxygen concentration varies from the respiratory rate we take. I may be doing 12 breaths per minute. The man next to me may be breathing 14 breaths per minute, and my tidal volume may be 500 every breath. The other patient may be doing 600, 700. So because the lung compliance is different, the lung capacity is different, the way we breathe is different. Even though you're giving only 2 liters oxygen to both the patient, but because of these variations, the FiO2, which is the fraction of inspired oxygen achieved by the patient, will be completely different. That's the reason nasal cannula comes under a variable device. Okay, just go back to this side. So delivery system, variable versus fixed. So what is variable performance? As I said, you can give a flow of oxygen from 1 liter to so many, up to 15 liters, but the oxygen, fraction of inspired oxygen varies from the respiratory rate and the volume of breath. Okay, let's go into this back again. So what is the advantage of giving somebody oxygen with a nasal cannula? Of course, it's comfortable, it's cheap. The important thing is a patient can eat and drink and talk. But the disadvantage, as I said, the FiO2 varies, depends on the respiratory rate, depends on the tidal volume. And you make sure the patient has got a patent nasal passage, because oxygen is going through the nose. And it can be easily dislodged. In many occasions, I've been to hospital and I've seen patient nasal cannula, patient sleeping. Either the nasal cannula will be sitting on their cheek, or sometimes in their mouth, or it's completely moved away from their nose. And it can cause significant irritations, and I've seen patients having a nasal bleed as well. I'm not saying this is bad. I'm just putting everything black and white. So you got advantage and you also got a disadvantage. But the important things to understand is the nasal cannula is a variable oxygen delivery system. You can tell only how many liters of oxygen patient is getting. You cannot assure and say patient is achieving this much percentage of oxygen. Let's see another variable device. But important thing to know about your nasal cannula, you can give only from 1 liter to maximum of 6 liters. Anything more than 6 liters can cause significant irritation to the nasal passage and can cause significant bleeding. And a patient wouldn't be comfortable. Second variable system device we are going to talk about is a face mask. I think you might have all seen this one, patients on face mask. So the flow on the face mask varies from 6 liters to 10 liters. Obviously, we are talking about medium flow. So we talked about flow, low flow, medium flow, high flow, low flow from 1 to 6 liters, and medium flow from 6 liters to 10 liters, and high flow from 10 liters to 15 liters. So this particular mask is a medium flow mask. So you will be giving oxygen 6 to 10 liters per minute. So again, you can only tell how many liters you are giving to the patient. You won't be able to tell what percentage of oxygen the patient is achieving. So if you look at the slide, it says very clearly O2 delivered from 35% to 55%. That's the FiO2 you can give, but you can't tell what exactly they are getting. So that's the variation. So what is the advantage? Simple to use, available with ear loops, and prone patients. The disadvantage is some patients are claustrophobic. They may say, oh, I don't like this on my face and it's suffocating me. And again, it interferes with eating, drinking, and talking. And again, it can irritate the skin because the oxygen directly going on the skin and face. Something important to stress here, if you choose to give somebody a face mask, it's important you give a flow anything more than 5 liters. The reason for that is if it is not anything more than 5 liters, there is a high risk that patients can breathe in what they are breathing out. So of course, you know what patients are breathing out is carbon dioxide. They are likely that the flow is not good enough to flush the CO2 coming out of the patient nose. The patient may end up in breathing in what they are breathing out. So if it's a simple face mask, something you need to know, the minimum flow required for that particular device is anything from 5 liters to 10 liters, not less than that. Then another variable device includes a partial rebreathing mask. Why it's called a partial rebreathing? This comes under a high concentration, high flow device, because you will be giving oxygen anything from 10 liters to 15 liters, and it delivers oxygen up to 50 to 70%. So if you really look at closely the picture of the mask, you got holes on the side. On the left hand side, the holes are very clear. On the right hand side, you got a little mesh valve on them. So what is the reason for that device? So every time the patients breathe in, the oxygen inside the bag, that's the reason it's got a reservoir bag. The bag delivers the oxygen to the patient. So there is a little valve on the top, opens it, allow the oxygen to flow from the bag to the patient. When the patient breathes out, the valve shuts down. So whatever the patient is breathing out, which is carbon dioxide, does not go back in the bag, but it goes outside through the holes on the side of the mask. But only one side there is a valve, there is another side, still the room air can get in. So that's the reason it's called the partial rebreathe mask. The amount of oxygen concentration you can achieve is up to 50 to 70%. The advantage, you can give high O2 concentration to patients. For example, if your patient is really low on saturation, you want really fast to improve their oxygen saturation, this is one of the best way to use. And commonly you may see this particular mask are used in situations like respiratory arrest, cardiac arrest, poisoning, or a patient is unconscious but still breathing. In those scenarios, you will see these kind of masks are used in the ambulance or in casualties or in A&E. Again, the problem is the FiO2 varies. It depends on the patient tidal volume, respiratory rate, and the fit. If the mask is not fitted properly, if there is a big gap between the skin and the mask, then most of the oxygen can leak out. So the patient may not be able to achieve the oxygen concentration you want them to get. This is called a non-rebreathe mask. This is another type called variable oxygen delivery system. Obviously, you might have seen this again. If the only difference between the one I shown before, the one in now, is you got the two little green valve on both sides of the mask. So the advantage is every time patients breathe in, the oxygen comes from the bag. When they breathe out, the valves on both sides opens up and allow the carbon dioxide, the patient's exhaled air, to go out. When they breathe in, the valve shuts back down again, and then the oxygen flow again from the bag. So patients, very, very minimal chance, or literally when I say less chance, patients may not be able to breathe in what they breathe out. And if you want your patient to achieve maximum oxygen concentration, this is one of the best device available on variable system. So you have to set 10 to 15 liters. The aim is to fill the bag as quick as possible, and you are aiming to achieve 90 to 100% oxygen for your patient. So the advantage is this is a higher level O2 concentration delivered, no rebreathing. But again, the problem is the oxygen percentage can vary from respiratory rate, how quickly the patient is breathing. And it's very important you do not give anything less than 10 to 15 liters through this device. Let's go back to this and let's say talk about what is the common problem happens here. Again, this particular presentation is aimed for adult patients. So we are not talking about pediatrics here because their lung compliance, their lung capacity is completely different. So whatever I'm talking about this is suitable for adult patients only. Okay, so in nasal cannula, I haven't seen much mistake happen. A couple of times I come across patients are put on more than 6 liters oxygen via nasal cannula because they don't like mask, because they're claustrophobic, but their oxygen demand is high. For example, they might have tried them on 6 liter oxygen, but their saturation must be very, very low, still not acceptable level. So then somebody would have gone and put the oxygen up to 8 liters or 10 liters. That is not the right practice. If patients are not achieving their oxygen level, obviously the doctors have to be informed. The doctors may have to consider doing a blood gas analysis because something is not right with the patient. So patient is not improving, so underlying problem has to be sorted out. So the blood gas has to be done. Then patient may need to be transferred from ward to high dependency or ICU. So no point in keep going up and on oxygen and cause nasal bleed and other problem. Basically, by doing this, you are masking the symptoms. So patients may be deteriorating, and we are trying to not look into that properly because we're trying to increase the oxygen to achieve the saturation. So we need to find out why the patient is not achieving the saturation we want them to achieve. This device, very common mistakes I've seen is patients will be put on 1 liter, 2 liters, 3 liters. But we know now this particular device is designed, you need minimum either from 5 or above liters of oxygen to stop the CO2 rebreathing. If you don't do that, if you give only 2 liters or 3 liters oxygen through this mask, patients are likely to breathe in what they are breathing out, and then they can develop CO2 retention. In between this device and this device, the common mistake I've seen is patients must be improving. So what they've done is, what they've done is they try to wean the patient from the oxygen. They end up in reducing the oxygen flow from 10 liters to 8 liters, 6 liters, and 5 liters. Remember, I said this mask is very, very good mask if you're aiming to achieve high oxygen concentration. Sooner you fill the mask, sooner you fill the bag, it's better for the patient because the oxygen is readily available to flow towards the patient face. So less flow to this device, the bag won't be filled faster, or it will be inadequately filled. Patients will be breathing and emptying the bag will be completely sucked and emptied, but patient will be continue to breathe. So you're not supplying the right amount of oxygen to the patient. So that's very common mistakes I've seen is patients will be put on non-rebreathing mask, but the flow will be set to 5 liters or 6 liters or 8 liters, which is not the correct practice. So if you're going to use this mask, the minimum flow has to be from 10 liters to 15 liters. Either this device or non-rebreathing mask. For both of them, The flow has to be 10 to 15 liters. So we need to know the patients who do not require controlled oxygen. For example, all the devices, nasal cannula, simple face mask, non-rebreathing mask, or partial rebreathing mask, all those devices comes under uncontrolled oxygen delivery system. The reason for that is you can only tell how many liters you are giving, but you cannot tell how many percentage the patient is achieving. Even if you're able to tell the percentage, there is only a variation. You may be able to say, oh, patient is getting from 50 to 70 or 50 to 90. You can't specifically say how much FiO2 patient is getting. So if your patient is asthmatic, pneumonia, bronchiolitis, respiratory distress, cardiac arrest, respiratory arrest, pulmonary embolism, shock, sepsis, hypovolemic shock, cardiac failure, myocardial infarction, carbon monoxide poisoning, in this situation, you don't have to worry about controlled oxygen delivery system. You can just use any of these devices to achieve your oxygen saturation is appropriate for that particular patient. I hope you guys have a clear understanding of the variable device and what is the advantages and disadvantages. Now, let's talk about a fixed oxygen delivery system. When I say fixed oxygen delivery system, I'm talking about if the patient is on this particular device, you should be able to tell how many liter patient is getting and how much FiO2 you are giving to the patient. So for example, you may be able to tell, oh, that patient is on 2 liters oxygen and we are giving 24% oxygen concentration to the patient. Let's see what and all the devices available to do that. So what and all the particular devices are called Venturi masks, or you can say Venturi devices. So the aim is to deliver constant oxygen concentration. So if you wanted to give 24% or 28%, you can give that to the patient. So it is available from 24% up to 60 liters, 60% oxygen, not more than that. Unfortunately, that's one of the biggest disadvantage. You can give only up to 60% of oxygen through the Venturi devices. It's ideal for patients with a type 2 respiratory failure. So I'm talking about patients with COPD, chronic obstructive pulmonary diseases, where they're very, very sensitive to oxygen, because you don't want to give too much oxygen and to take the respiratory drive off. So this is perfect and ideal devices for somebody with the chronic conditions. And this device does not allow rebreathing. And the disadvantages, nothing major, only thing is it cannot be humidified. Fixed oxygen delivery system. Let's look at this. So these are called Venturi system. To simplify this, the manufacturers have come with a really clever plan. All these devices are individually color coded. So if you find a valve which is blue, which is obviously designed for 24% oxygen, and white valve is designed for 28, orange one is designed for 31, yellow for 35, and red for 40, and green for 60. As I said, the FiO2 you can give using the fixed devices only varies from 24% to 60. You cannot give anything more than 60%. Why it is? Because to give 60% oxygen, you have to set the flow meters to 15 liters. So I already told you in the beginning of the presentation, the flow meters we use in the hospital is got a maximum capacity of 15 liters. That's the reason the Venturi valves are capped to give 60% maximum with the 15 liters flow. Then how do you may say, oh, how can I give 24%? How do I know how many liters oxygen I have to set to give the 24%? It's very simple. You don't have to worry about it. You look at the valve. The valve is very clearly printed on the body of the valve on the side. 24% oxygen, you need to set 2 liters. The manufacturer's instruction would be very clearly on the valve. For example, if you take the white valve and it will say to give 28% oxygen to a patient, you need to set the flow meter to flow 4 liters. So it's very, very clear and black and white. You don't have to get confused. You don't have to ask anybody because it's a manufacturer instruction. You have to follow the instruction. Look at the color of the valve. Look at the percentage you are going to give, and on the side it will tell how many liters you need to set on the flow meters. To make it very clear, I'll give you an example here. You can see it's a fixed oxygen delivery system. So on the body of the valve, it says 35% oxygen. On the side, it tells you a 10 liters oxygen you need to give. So the question is, whatever the oxygen we are giving, whether it is 1 liter or 2 liters or 3 liters or 10 liters, it's 100% oxygen, right? Because the percentage of oxygen coming from the flow meter is 100%. Only the flow is different, 1 liter to 15 liters. So according to this, the flow manufacturer instruction, it's very clearly written, you need to set the valve to 10 liters flow. So once you give the 10 liters oxygen at the bottom of the valve, the room air 21% enters the holes on the side of the valve and dilute that 100% oxygen to 35% oxygen when it comes out. That's the reason every valve on the side, the hole will be different to provide exact amount of oxygen concentration. So you may say, oh, that may not be true. How is that even possible? To do that very simply, I carried out a little test in my hospital. Obviously, these devices cannot be out unless they've shown all the experiment and went through all the quality check to show that what they're saying is true. So I got oxygen analyzer. So I did a little test on a Venturi device. I put the oxygen analyzer at the top, connected the valve, and given the oxygen flow which they asked me to give. So what came out was exactly what was printed on the valve. So you can definitely trust that manufacturers would have gone through all the very clear, strict criteria before this manufacturing device was out. So these particular devices are called a fixed oxygen delivery system. So it's important, it's very simple, it's very much color coded, you can't go wrong, and then the manufacturer instruction will be on the side of the valve. So 24% will be 2 liters, 28% will be 4 liters, orange maybe 6, yellow 8, red maybe 10 or 12. As I said, different manufacturers have a different instructions, but I would strongly recommend you to follow the instruction on the valve. It will be printed very clearly to give specific oxygen concentration, how much liter of oxygen you should give to the patient. So, which type of patients we are talking about who require controlled oxygen, which is the Venturi devices we talked about. Controlled oxygen means, again, I would like to explain this. You should be able to tell how much flow you are giving, how much percentage of oxygen patient is achieving. Okay, so the patients who need to be on controlled oxygen, which is fixed oxygen delivery system, is a COPD, chronic obstructive pulmonary disease, exacerbation of cystic fibrosis, all your neuromuscular disorder patient with the chest wall disorders, morbidly obese patients. All these patients are high risk of developing CO2 retention, and you can take their respiratory drive off, and then you can push them into CO2 narcosis, which is a high carbon dioxide level, and then they can go into respiratory failure, and then they can go into respiratory arrest. If you want to avoid all these complications, you need to be very mindful and make sure that these patients are started on controlled oxygen delivery system. I just wanted to read out a statement. The effective oxygen delivery system should be a universal standard of care and should be made more widely available. When I say effective oxygen delivery system, we are not talking about oxygen therapy itself. We are talking about all the equipments available to provide this oxygen. So very commonly we may have face mask, nasal cannula. If your hospital don't have these Venturi devices, I'm not saying you don't have, I'm saying if you don't have, it may be a right time to talk about this to your managers and have these equipments available to provide the right amount of oxygen to your patients. All of these conditions, I want you to be very clear about this. Start with oxygen therapy of 24% Venturi, which is your blue valve, and it will say 2 liters, and then you can slowly increase to 28. For example, the advantage with these devices, if somebody is not achieving their oxygen saturation, you could start them on a basic low one, which is your 24%. start them, monitor them, do their saturation, and see how they're responding. Obviously, whatever their underlying problem, also the treatment would have been started. And if they're not achieving the saturation, then you can go to the next step. Your next step is very clear, 28%, which is your 4 liters oxygen, which is your white valve. If they are not achieving that, then you can move on to yellow, which is your next step, which is 30% or 35%. So you've got a very clear guidelines, you've got a clear idea what you are started with and how much you are going up. But again, the important thing is no point in going up and up. Again, the medical team need to be involved. Why their oxygen saturation levels are not going up? Maybe they wanted to do arterial blood gas analysis. Once if the blood gas is done, they may want to escalate the patient care to the next level, or a patient may need to go on non-invasive ventilation. Or if they are failing on non-invasive ventilation, then patient may have to be intubated. But all those things will be decided by the medical team. But at least if we start the basic level properly on a right amount, we'll have a clear understanding how the patients are responding or they are not responding. And then we can escalate the treatment appropriately. Now, situations where controlled oxygen not applicable. For example, your patient may be cystic fibrosis, your patient may be a COPD, your patients may have a neuromuscular problem, but if they are coming into hospital with these kind of problem, a shock, a sepsis, a major trauma, a near drowning, anaphylaxis, major pulmonary embolism, this is not the time you will be starting your patient on 24%, 28%. This is a life-threatening situation. The aim is to achieve maximum oxygen concentration. So they may be started on one of those non-rebreathing masks in casualty or A&E, because here what we are dealing is something very, very dangerous condition. Patient could die anytime. So if they are not treated appropriately, then it's risking and costing their life. Your patient may be, again, I said, in actual scenario, for example, if your patient is coming with a chest infection or a pneumonia or something like that, then it's okay. But if they're coming with a life-threatening condition like this shock and sepsis and trauma, in all those scenarios, you need to consider the oxygen device which can give a maximum oxygen concentration, which will be one of your non-rebreathing mask. Once they regain their consciousness level, once their clinical condition is stabilized, then we can downgrade them to the appropriate level of oxygen therapy. But until then, this is important to manage their hypoxemia properly. Right. If a very common practice, even when I was a junior physio, what we have done in India is humidification. Most of the time, we give a cold water humidification to patients if they are on oxygen therapy. And obviously, we know that is not the right way of giving humidification. The actual humidification is the water has to be 37-degree body temperature, and that is the only way you can achieve an optimum humidity of 44 milligram per liters. So if you're using a cold water humidification, if they call humidification, but that's not really a right way of humidifying the oxygen. So what is the current practice? So what device is available which can give low to high oxygen flow, but also can give exact oxygen concentration? That means you can give a fixed oxygen, but you can also give a high flow. So that particular device is called OptiFlow, which is a nasal high flow oxygen therapy. I am not particularly talking about any particular company here because I'm not recommending anything, but the only one I have used in my clinical experience is Fisher-Paykel, because they're one of the pioneer manufacturer of these devices. So this is called, what you're seeing on the picture is called AirVo2, one of the device which can give OptiFlow, nasal high flow oxygen therapy. So what does it do? What is OptiFlow? OptiFlow is an oxygen delivery system designed by Fisher-Paykel Healthcare. The OptiFlow offers the ability to comfortably deliver a complete range of oxygen concentration and flows to extend the traditional boundaries of oxygen therapy. This is achieved through integration of heated humidification and a precise blend of air and oxygen via nasal cannula. So this is where I am going to really contradict myself a little bit. Please try to listen, and then you will be able to understand why I am saying this. In normal nasal cannula, I mentioned to you, only 1 to 6 liters oxygen can be given maximum. Okay, because anything more than that can cause a significant irritation to the nasal cavity and can cause nasal bleed, and it's not appropriate to give more than 6 liters. But in this device, we are going to give minimum 30 liters of flow and maximum of 6 liters of flow through the nasal cannula without causing any damage to patients. Why does it work? Two of the key elements are heating and humidification. Provide better tolerance and mucosal clearance. So most of the time we know people with a respiratory problem, a pneumonia, they all have a problem with the mucus, coughing and expectorating, because the mucus can be very thick, and obviously pneumonia can produce all these secretions. By giving OptiFlow device, you are heating and humidifying the oxygen you are giving to the patient. The flow drives accurate delivery of oxygen, washout of anatomical dead space, and provision of low-level positive airway pressure. So basically what the machine does is, the machine sucks the room air and produce the flow you wanted them to get. The aim of the flow is to exceed your inspiratory demand. For example, everybody have a little demand. For example, when you breathe in, the amount of air flows into your nose. That's because of the demand you have. So if you're exceeding the demand by pushing a lot of air into your nose, but remember, I'm talking only about the flow of air here. You feel like, it's like, imagine you go in a car, you put the window down, you feel like the fresh air coming and hitting your face. And it's exactly the same feeling, the air literally sitting in the patient's nose for them to breathe in. So if by exceeding their inspiratory demand, you're making their breathing a lot easier. Then you may say, oh, come on, how they can manage 30 liters of flow? That I said, the machine can go give a flow from 10 liters to 60 liters, okay? But they're all not oxygen. What it is, a flow, which is the machine, sucks the room air and heats it, humidifies it, and then give it to the patient. If you go back to the previous picture here, you can see the device. So the bag of water goes into the chamber. That's what the humidification is. The chamber heats because you've got a heated plate on it. And that's where the air is heated and humidified. And then it comes to the patient by the big tube, and it goes into the patient via nasal cannula. In this picture, how does it work? A medical air, or you can say the room air, and oxygens are fed into the unit. The percentage of the oxygen required and the flow rate are set. So you need to, so what is the recommended guidelines, and the research shows the minimum flow is required to the patient to exceed their inspiratory demand is 35 liters or more. So what we do, we set the flow to 30 or 35 liters, and then if we try to give extra oxygen on the side of the machine, and you can see on the second picture, a little green tube is the oxygen you're giving. If you don't give any oxygen, what the patient will be achieving is the room air oxygen concentration, which will be your 21%. By feeding extra oxygen into the unit, the FiO2 automatically goes up. So if, example, if you give 2 liters or 3 liters or 4 liters or 5 liters, you can see on the screen how much oxygen you're trying to give to the patient. For example, in this method, you can give controlled oxygen to your patients with a chronic respiratory problem, like your COPD or cystic fibrosis, or patients with a neuromuscular condition. So by this way, you're also giving exact oxygen concentration, and also you're giving excellent flow to increase their, achieve their inspiratory demand, and also you are heating and humidifying the oxygen you're giving. So the patient has got excellent benefit of humidification, their tolerance, and you're giving exact oxygen concentration, And also, what is that one of the advantage of nasal cannula, which we read in the first slide? Patient able to eat, drink, and able to communicate, so which is a very, very important thing. So how does it work? Medical air and oxygens are fed into the unit. The percentage of the oxygen required and flow rate are set. The oxygen and medical air, once mixed, passes through the heating and humidification chamber and on to the patient. So this is a very simple graph to explain. Oxygen, medical air goes in, mixed to the appropriate flow rate and concentration, heated and humidified, and goes to the patient. So the machine, you can set the flow rate from 0 to 60 liters. Remember, it's not oxygen you're setting, it's the flow of air from the machine. Then you can add the additional oxygen from 21% to 100%. So how can you say it's 21% from 100%? You keep increasing the flow from the flow meter. The little device on the machine tells you, by, for example, if you set the flow to 30 liters, if you start the oxygen from 2 liters or 3 liters or 4 liters, on the little screen, it will tell how much percentage of oxygen the patient is getting. So in that way, you know very clearly how much percentage of oxygen you are giving it to your patient. So fundamentally, this particular device you can use to any patients, doesn't matter despite of their clinical condition, because you should be able to tell how much percentage of oxygen patient is getting, and also your heating and humidifying, which is the right way of humidification, and fundamentally patient's recovery will be a lot faster and their tolerance will be better. And you don't have to keep changing the devices. If the patient is on oxygen therapy for 5 days, you may start the patient on nasal cannula for first days. If they're not responding, then you may go into face mask or you may go into non-rebreathing mask. But with this device, you'll not keep changing the device. One device set on the day one, and the same device is taken off when they are ready to be discharged from home or when they are clinically better, because you're just literally stopping the machine and taking the oxygen off, which is the nasal cannula off. You can go up on oxygen, you can come down on oxygen, you can do a lot of variation with this device, with one device. You're not wasting many equipments. The flow rates used clinically are from 30 liters up to the level that patient can tolerate. So higher physically seen patients are very, very unwell. We have gone up to 60 liters flow. You will be asking, hang on a minute, is it possible for a patient to tolerate 60 liters of flow through the nasal cannula? Yes, it is. It is possible, and without any problem, purely because of heated and humidification. If you take the heat and humidity off, then you're pushing the dry air into the patient nasal cavity. Within a matter of half an hour, patient will have a significant nosebleed. And first of all, they won't be even able to tolerate 10 liters, let alone 30 liters. But with the heating and humidification, this is possible. And I personally know Fisher Packle is available in India, and they are one of the leading companies, pioneer of manufacturing these devices. They would be very happy and willing to give a free trial, because when it comes to my practice, when the rep comes and meets us, we always try first, which is called a free trial period of a month. So they will be able to give you the equipment, they will set the equipment for you, they'll give you all the things needed. You do a 1 month trial or 2 months trial, it depends on how much you need. Then you can collect those evidence and really compare yourself. Is it really working? Is the patients are improving? Then we are doing something right. So the oxygen percentage will depend on the individual patient. As I said, I'm not recommending any particular oxygen percentage. It depends on their clinical need. The biggest advantage with this particular device, you can give a controlled oxygen. You can also give uncontrolled oxygen. You can give oxygen concentration from 21%. That means if you don't input any additional oxygen, the patient will be getting 21% oxygen, which is room air. You can go up to maximum 100% oxygen, because if you turn the 15 liters flow into the device, patient can achieve. But again, if somebody need 100% oxygen, you need to really think, how stable are they? What is going on with them? They may be really unstable. They may need to be escalated to the higher level of treatment. They may need further investigation. Obviously, all those things will be decided by your consultant and your medical team. So with this device, it's not one particular set of devices available, not only nasal cannula. If your patient is a tracheostomy, this is one of the best way, because imagine if your patient is a tracheostomy, you are completely taken their natural humidification process, because your humidification process happens in your nasal cavity. With the tracheostomy, you've taken the process away. So that means if you give a dry oxygen to your tracheostomy patients, they are likely to block their tracheostomy tube with a mucus plug. So you may say, oh, I'm giving the oxygen via cold bottle humidifications. We discussed that's not the right way of humidification. Humidification process involves 37-degree body temperature, because that's what normally happens to us. It doesn't matter what is the outside temperature. When the air, for example, in UK at the moment, the room air temperature is 15 degrees Celsius. I breathe in. When it hit my nose, it's 15 degrees. When it goes into the nasal cavity, it becomes 20. When it goes into the main bronchus, it's become 25, 30. When it reaches the main right and left main branches, it become 37. When by the time it reaches the alveoli, I'm getting my optimum temperature of 37 degrees, which is my body temperature, and also I'm getting my optimum humidity, which is not possible for these tracheostomy patients. But with this device, you can change the interface from nasal cannula to the tracheostomy device. But obviously, it's a single patient use only, so you don't move the machine and change the interface to a different patient. Once the machine is set up for that particular patient, it stays with that patient. Benefits of OptiFlow with optimal humidity. What is the advantage of patients? What is the advantage of clinician? Patient is comfortable oxygen delivery system, can continue to eat, drink, and talk and sleep, a broad range of flows and oxygen concentration. For clinician, less attendance, time assisting the comfortable of the patient, no need for multiple oxygen delivery devices and interfaces. I told you, no need to start the nasal cannula, change it to a face mask and then non-rebreathing mask. You don't have to keep changing the interface. Increased confidence in the actual fraction of inspired oxygen. You know your patient is getting exact FiO2 you wanted the patient to get. Patient advantages again may reduce the need for non-invasive or invasive ventilation. In so many occasions, in my personal experience, patients looked very unwell and needing that we thought the patient may have to go to intensive care unit for non-invasive ventilation or for even intubation. So many patients made a huge successful recovery with this device, with this type of oxygen delivery system. Obviously, we have got patients, I'm not saying 100% recovery. I have seen patients, maximum number of patients making a good recovery, but few patients, unfortunately, because of their underlying conditions are not that well, they need to be escalated. There are patients who got intubated, or there are patients who got into non-invasive ventilation. But again, if the patient is going on non-invasive ventilation, and if you want them to give a break for their lunch or food or medications, you can take them off and put them on OptiFlow, and you know that you're providing the right amount of treatment, and you know that patient is getting exact fraction of inspired oxygen. So there is a bit of a confidence there. So what we do is, the way we wean the patient from non-invasive ventilation, we keep the OptiFlow ready. We take them off, try them on OptiFlow for 2 hours. If we feel like they're getting tired, or if their carbon dioxide level goes up, then we will switch over them to non-invasive ventilation. So you can alternate the treatment, and then you can see slowly the amount of time they're spending on OptiFlow is getting longer, and then the non-invasive ventilation is getting shorter. And then you completely stop the non-invasive ventilation, and then continue them on OptiFlow for a few days. Improved respiratory efficiency, better secretion clearance. I told you, if you give him an optimum humidity, 44 milligram per liter, that is better than, this is one of the best way to clear the mucus, because the humidification helps with the sputum viscosity, consistency. It will be easy for patients to cough and clear. So you don't have to unnecessarily prescribe nebulizers, like some people still prescribe saline nebs or carbocysteine or mucodyne medications to loosen the secretion. So all those medications you can stop, because you are naturally helping the patients to clear the secretions. And also, it's easy for the nurses to do oral care and maintaining the moisture of the oral mucosa. You know, imagine if patient is on non-invasive ventilation, how it's possible for nurses to do their mouth care or oral care? It's not possible. It's a really fantastic device to wean the patient off invasive and non-invasive ventilation. We have done it in loads of occasions, and we have such a good success rate. What is the contraindication for this device? Obviously, it's a nasal obstruction or irritation, or if there is a facial fracture or burns, because the cannula strap goes on the face. Apart from that, there is not many contraindications for this particular device. So usual precaution complication with oxygen prescription. So imagine you're using precaution complications with the normal oxygen therapy, which I discussed before, which do not occur with the high flow nasal cannula oxygen therapy, which is optiflow, induced hypoventilation due to CO2 retention, because very less chance of CO2 retention because you are giving the FiO2, you are giving the exact amount of fraction of inspired oxygen, and you got control over it. You know exactly how much patient is getting. And oxygen toxicity, absorption atelectasis due to high FiO2, drying of nasal or pharyngeal mucosa, inadequate flow resulting in lower FiO2 delivery. High risk of aspiration, because if imagine if the patient is on face mask, if they are likely to be sick, sometimes they can aspirate their own sickness and can cause aspiration pneumonia. So all those risk factors are significantly reduced. Use of nasal high flow O2 in clinical setting. What we do to prevent invasive ventilation, help with weaning from invasive and non-invasive ventilation, help with weaning from tracheostomy, prevention of admission to ITU, HDU with the portable units on the ward. Because these devices are such a portable units, you can use it in the respiratory ward or any ward with appropriate training. So these patients can be looked after in the ward. Obviously, indirectly reduces the need for bed in intensive care unit, which is a huge cost, isn't it? Because it can cost up to 10,000 rupees a day to 20,000, 30,000, depends on the need of the patient in intensive care unit in India. So imagine if these patients can be looked after in the ward, huge cost saving. Obviously, not for the hospital, definitely for the patients. So what I want to do, we'll do a little quiz. It's basically a self-reflection. It's the end of my presentation, but if you really listen to this presentation, you can answer yourself a small, very, very simple questions, and then we can call it a day, and then you can ask your questions. What percentage is oxygen in room air? So what percentage of oxygen in room air, which I mentioned in my first slide. So the answer for that is 21%. If you get it right, that's great. What purpose is oxygen used for? If you already answered that, so the purpose of oxygen is for hypoxia, which is low oxygen in your blood. Does oxygen need to be prescribed? And obviously, you know, it is a prescription drug, so the oxygen has to be prescribed. If it is not the current practice in your hospital or where you do, you can definitely recommend that, or you can speak to your clinical lead or doctor, and basically it's put you on a safer side. There won't be any contradiction between you and the doctor. Nobody can blame you, because if it is written, it is written. So you can ask, see, you can say that this is what you asked me. And also, if they are prescribing, because you got the right knowledge about oxygen therapy, you can explain to them. For example, if a doctor prescribe 5 liters of oxygen via non-rebreathing mask, you can tell that is not the right way of giving oxygen by a non-rebreathing mask, because the minimum flow required to give non-rebreathing mask delivery system is 10 to 15 liters. So those things can be sorted out, and the right amount of oxygen can be prescribed to the patient. Is it important to wean the patient of supplementary oxygen? Yes, it's very important. As much as you start, you need to wean them off, obviously, because they need to go home. That's not the answer for why. The reason for why, if patient is on oxygen for a very long time, as any medications, oxygen also has got side effects. So we don't want any patients to develop, we call them oxygen toxicity. So we don't want them to develop oxygen toxicity. So it's important to wean the patient off the supplementary oxygen. What type of respiratory failure can supplementary oxygen used for? Obviously, we know there are 2 types of respiratory failure. Type 1 is low oxygen. Type 2 is high carbon dioxide and low oxygen. Obviously, the oxygen can be used for both the type of failure. But in type 2 respiratory failure, you need to be extremely careful how much you are giving. This is where you need to use your controlled oxygen delivery system devices, which I said, the Venturi valves, which is the colorful valves from white all the way to green. For example, simple one, name a variable system, which if you can name a variable system, that means the oxygen, you can tell only the liters of oxygen, can't tell the percentage. So it can be from nasal cannula, face mask, simple face mask to partial non-rebreathing mask to complete non-rebreathing mask. The last question is name a fixed system, which is, the device which can give a specific flow and specific oxygen concentration, which is called Venturi devices, a Venturi valve. Or you can also say nasal high flow oxygen therapy, which is OptiFlow by Fisher-Packard. So these are the references which you can read to extend your knowledge on oxygen therapy, British Thoracic Society guidelines, British National Formulary, and also World Health Organization. They got a really good little simple presentation on oxygen therapy, which will give you a clear idea. So I really like to take this opportunity to thank you all for attending this webinar, and also particularly Franklin for providing this opportunity, and also for HAMSA Rehabilitation for giving this opportunity to talk to you all. And I'm ready to take a question now, and also I'm happy to speak to Franklin.
Thank you so much, David, for giving a fantabulous presentation. It was quite illuminating and was quite explicit. And this is a Q&A session. Attendees, please, you can post your question in Q&A, where the presenter will be answering your question. So it's going to be I'm going to pick 5 or 10 questions, not more than that, because we are out of time. The one person has asked, Mr. David, is it true that wearing masks for a long time leads to hypoxia?
Basically, when it all depends on what and how much oxygen flow we are talking about. There are a lot of things comes under oxygen toxicity. So a couple of oxygen toxicity, including nasal irritation or airway irritation. And there is something called absorption atelectasis. So absorption atelectasis is not because there is too much amount of oxygen flow into the alveoli. The alveoli shuts down. So the alveoli is starting to collapse. So you must be thinking that you are giving oxygen, but the patients are not improving. Once the alveoli shuts down, the oxygenation also impaired. You need to remember, the lungs are massive. Even though we got bronchus, right main bronchus, left main bronchus, bronchioles, and alveoli, the only place where the oxygen takes place is the alveoli. If absorption atelectasis happens to these patients, obviously your alveoli are closing down. That means the oxygen is not adequately mixing with the blood, which can indirectly contribute to hypoxia. That's the reason sometimes we think, oh, I'm giving oxygen, why the patient is not improving? So that may be a time you need to do a chest X-ray where you can see these small changes of atelectasis in your lung fields. If that's happening, it is called absorption atelectasis, which can contribute to hypoxia despite of you giving oxygen. In that particular scenario, it may be ideal to slowly turn down the oxygen to see whether the patient is improving. No point in keep going up and up and up.
Next question.
Yes, sorry.
The next question. Okay. How do we decide how much oxygen the patient needs?
For example, I mentioned very clearly, you need to understand the background of the patient first. Is your patient has got chronic respiratory conditions, which is, example, chronic obstructive pulmonary disease. They got a significant history of smoking. Sometimes there may be diagnosed COPD, there may be undiagnosed COPD. If your patient is a confirmed COPD, then according to the guidelines, I'm not saying this, the BTS, the NICE guideline says their acceptable saturation is 88 to 92. If they are low on that, then you need to start them on oxygen. And for patients with a chronic condition, the best way to give oxygen is using a Venturi device, which is, you can tell the liter, you can tell the percentage. So you start with the low oxygen flow first, which is your 2 liters, 24% Venturi device, and then see if their saturation improved to 88 and 92 by giving just the 24% oxygen, which is 2 liters, then that may be the oxygen they need for a couple of days. Once their underlying problem is treated, for example, pneumonia or chest infection, then you could try to stop those oxygen and see whether they're maintaining 88 and 92. If they're maintaining that oxygen saturation, then they may not need any more oxygen. But if you're treating a patient who's got a normal pair of lungs, but they got pneumonia, then their oxygen saturation should be 95 to 100. In that scenario, you could start them on 2 liters via nasal cannula or 4 liters via nasal cannula. The advantage of nasal cannula is because the patient can eat, drink, because by simply putting them on face mask, you're going to interfere with their eating, drinking, and communication, which is an important part of their daily activities. So you could start them on 2 liters, 3 liters, 4 liters, or 5 liters. If they're achieving 96, 97 with that amount, then that may be the oxygen they require until they get better.
The next question is, can physio prescribe O2 or humidification therapy?
Thing is, obviously, as I mentioned very clearly, if you're a physio and if you are having adequate knowledge with the prescription qualification, which obviously the hospital should be aware of, your clinician should be aware of, so that they don't contradict you or they don't come and tell you off for doing this, then you can prescribe. But if you're not a prescriber, but if you have adequate knowledge about oxygen therapy, if you have a good relationship with your work colleagues, you could recommend. But again, the clinician has to prescribe whatever you are suggesting. It's all to do with the clinical reasoning. The clinician has to agree with what you are saying, and both have a good understanding. Yeah, I completely agree with what you're saying. That's what we need to do. Then the clinician has to prescribe that. Then the nursing colleagues can follow those instructions. As I said, it doesn't have to come from physio. Even the nursing colleagues can talk to the doctors and recommend a specific particular oxygen therapy if you can justify it. Because most of the time we have problem is speaking to the clinician is what they're going to ask, how we're going to answer. If you have a clear justification with evidence-based practice, if they ask, can you show me the guidelines? So if you have the guidelines in your hand saying British Thoracic Society or NICE guidelines, then he will completely trust you. He will know, or she will know, you're not just saying it, you are talking with evidence.
Okay, I think this is the end of a session.
And somebody asked, what is the cost of the OptiFlow, and is it single use? The whole machine is not single use. The humidification system and the interface is the single device. You have to change from patient to patient. But once you set it up for a patient, I think it can go up to 14 days or 10 days. And then you have to change the interface. But most of the time, most of the patients normally make a good recovery in a period of a week. If it's taking more than a week, then obviously their care has to be escalated. But as I said, I'm not sure about the cost because the cost varies from country to country. What I would recommend is if you can look at OptiFlow in website and you can email them. They should be able to arrange a local representative area, depends on your area you live, and you can able to arrange a meeting with them, and then they should be able to provide you with all the details.
The last one question you have, David. What is your view on pre-oxygenation before out of mobilization, bed mobilization? Also, how many liters more should we increase by? We'll take it as this is the last question.
Right. First of all, what is your view on pre-oxygenation before out of bed mobilization? Right. So you need to know what I wanted to say is if you're going to mobilize a patient, ITU patient after prolonged bed rest, you're going to do a transfer or mobility. It's important to understand what is their existing exercise tolerance. What is their oxygen saturation? Obviously, these patients can be hooked up onto the screen or monitor, or you can use a portable oxygen delivery system. So obviously, you need to take if they are already not on oxygen, you need to check their existing oxygen saturation. If it's already acceptable level, then what I would personally recommend is you can keep the oxygen cylinder, portable oxygen cylinder, with the simple devices from nasal cannula or a simple face mask ready, standby. And when you mobilize them, it's important to keep the portable oxygen pulse oximetry in their finger. As soon as they're starting to move, or as soon as they're starting to walk, if you can see there is a huge fluctuation in their oxygen level. For example, if they're starting to desaturate, how much they are desaturating. For example, if a normal person, 95 to 100 is acceptable. If they are desaturating to 93 or 90, then you know maybe 2 to 3 liters of oxygen via nasal cannula may be able to fix that problem. But if they are desaturating significantly to 80 or less than that, which is putting the patient at risk, because you are inducing hypoxia by exercise. Maybe not, patient is not ready for a huge mobilization or walking. Maybe you can carry out bed exercises or simple transfers from bed to chair, or even standing with a Zimmer frame or a rollator frame and doing some marching on the spot. Until they are ready for that exercise tolerance, no point in putting the patient at risk. But I would personally keep so this is where what you should ask your clinician to write the oxygen on PRN basis. PRN may as required. So if they can write oxygen via face mask 6 to 10 liters or 5 to 10 liters, you can keep that as your guide, because the doctors prescribe that for you. If the patient is starting to desaturate, you can temporarily give that oxygen for a short period of time until their saturations come back to acceptable level. So that's called PRN oxygen therapy. So you need to ask your clinicians to write it, and you have to ask him to sign it and say PRN. That means they don't need oxygen regularly, but they need oxygen only during exercise.
I think, David, it's our end of our session. Okay.
Yeah.
And thank you for accepting our short notice and gave a tremendous presentation. Once again, I thank you. And thank you, attendees. And this presentation will be available in HAMSA Rehab YouTube channel. You can go ahead. And please, if you have any questions also, you can mail to us, and I'll send it to Mr. David, and he'll be answering it to you. And thank you once and all for the participants and physios and nurses. Thank you. And thank you. I'm winding it up. Thanks so much.
Thank you very much, everybody. Bye now.